Hi, I'm Krista Roshaw, and Krista Kyle is right behind me, and Tricia Blaine will be joining us momentarily. The three of us are the three day shift members of the BWH NICU Vascular Access Team. We're trying to get away from calling ourselves a PICC team because it's sort of evolved into more than that. So it's the Vascular Access Team, and we are logged into the Vault that way if you're looking for us. So this is a list of our names and our credentials as they release for the Vascular Access Team. Just as a note, we do try very hard to cover the schedule so that there's at least one of us on every 24-hour period. There's very few days that we don't actually have covered. Some days is, all of us are on. Some days it's just one or two. But and even if we're not here, we're accessible via the charge nurse. So if you ever have questions and you need to reach out to us, we're almost always available. So the objectives for this workshop are to review the vascular access equipment and supplies, review the insertion procedure for the PICC line insertion, and we will demonstrate the use of MST and ultrasound for PICC line placement as well. And then the last but not least, and probably the most important thing, is demonstration of the central line dressing change. It does happen occasionally that a fellow is asked to change the dressing, and it's always, where is everything? Where do I get it? How do we do it? So we'll cover that. So that metal cart is all the extra stuff. The purple cart on the right is the PICC cart that contains all the supplies that you would need to put in a PICC line or an extended well peripheral IV. The bottom drawer has PPE in it, and the jars are all labeled on the outside.
Stored in the clean utility room.
Yes. And that's the labeling to help you find everything. In the top drawer, we have consents for the parents to sign. The person who is placing the line should actually be, whenever possible, should be the person who obtains consent. Sometimes an exception to that is sometimes on the day shift we'll get consent for the night shift so that people don't have to call the parents in the middle of the night if the parents are here. There's also a teaching sheet in color to give to the parents that explains a little bit more about what a central line is. On the left there was a notebook that's our logbook. We put a patient sticker in that, and then we just put details about the date of the line placement, the size of the line, where the line is cut at, and where it's secured at. This is one of the drawers, alcohol, chlorhexidine, and iodine on the left. Need 10 cc syringes to draw enough heparinized saline, the needles. The center is a couple of different size tegaderms, and then sort of like a spongy material, the Methylax light that we use on the really tiny, like 24 weekers, that needs something sort of under the hub to prevent skin breakdown. And then over on the right, there's measuring tape, stat seals, and bio patches. We'll talk about what those are. And the cutter is that little green thing that's sort of 3/4 the way down on the right. We actually do cut the lines. We don't put the entire PICC line in. We used to do that and then coil it and secure it under a dressing. We don't do that anymore. That seems to be associated with more central line infections. So we cut the line to where we think we're going to need it to be based on the measurement. These are the MST kits. We'll talk about that. And in the upper right-hand corner is the transilluminated cover. These are all the different size PICCs. On the left are the sterile towels. Behind that are most of our PICCs are single lumen PICCs. We do have a couple of different size double lumens. The smallest we have is a 1.4 that's in the back. And the 2.6s don't actually fit in this drawer, but we'll show you one later. And then the bottom is the PICC dressing kit. And then on the right is the central line dressing change kit, which should have most of what you need. We do have to add a few things to the kit, and we'll show you that when we show you how to set up for line. And then this is your PPE. So stat seal versus viopatch. The stat seal is used, it's a little tiny round disc, and it's hard when you take it out of the package. It's used for excessive bleeding at the insertion site, for any gestational age, has to be removed after 7 days. When you first insert the line, there's likely to be some bleeding. We hold the stat seal in place for about 2 minutes, and that should sort of start to break down the stat seal, and it forms granulation tissue at the insertion site to help control bleeding. The biopatch is used when the infant is 28 weeks and 1 week of age. Less than that, we don't put anything on. So when we do that first dressing change, we switch out the stat seal and replace it with a biopatch, which is impregnated with chlorhexidine, so it helps to prevent line infection. That needs to be changed every 7 days. So our policy is to change dressings every 7 days, or when it's soiled or lifting, or if it needs to be done sooner.
So the one exception to the every 7 days is if the baby is less than 28 weeks and has already had the first dressing change. If there is no biopatch and it's a perfectly sealed dressing, it can go past the 7-day mark.
This is the most overwhelming part for people. There's so many choices, there's so many things, and it took us even just a long time to get used to all the equipment. So everything that's listed here is what you probably will need to place a PICC line. I won't read all of it because obviously you can read it for yourself. And so in addition to all of those things, we then also have to flip a couple of additional things onto the seal that we may need, but we'll show you that. The extended dwell peripheral IV is this little station right over here. We have a couple of different types, and we'll just show you those. You guys probably won't be doing them. It is a peripheral IV, but because we put it in like a central line, we include this as part of this workshop. But we do use a lot of them in the unit. It's a 2 French. We tend to use it for babies that are vascular access nightmares. We tend to use it as sort of like a rescue thing, but need IV antibiotics or IV fluids for, likely beyond a day or 2. We may start to evolve with that and be using these a lot more and just putting in babies that we know need them right from the get-go, but we're not quite there yet. They are a good option. They can stay in for up to 29 days. We've had some, I don't think we've had one last that long, but we've had some last for several weeks, and it's been life-saving, life-saving, but it's been very beneficial to the baby and minimize the number of sticks. It's contraindicated in infants requiring vesicant medications or obviously central CPN because it is a peripheral IV. So some examples of that are calcium dopamine, Dobita, obviously anything that would require central access.
We get a lot of questions about the E-pivs about whether or not they need heparin. They only need heparin if they're running at a KVO rate, which is 1 cc an hour. Anything over that, they don't have to have heparin. And the other question we get a lot with the E-pivs is whether or not they can be hep locked. Yeah. And that's always a discussion, case-by-case basis, ideally with one of us from the team there. Sometimes they can be hep locked and sometimes they can't. It kind of depends on what you're using the E-piv for and how desperately you need to keep it.
And when you say contraindication, is it that you just can't run those things through it? Okay. Yeah. And so if the baby has a central line for that and you're using the E-piv for something else, you can have an E-piv as long as those things aren't going through it.
Correct. Great question. A little bit. So these are the different types of catheters that we have. The smallest, no, these are PICCs. The smallest PICC that we have is a 1.4 French that's used for infants less than a kilo. The 2 French is used for infants greater than a kilo. We do have a 2 French double lumen versus a 2.6 French double lumen. We don't use a whole lot of 2.2 French double lumens. If we're going to go for a double lumen, we usually go for 2.6 if the baby has a vessel that would support it. The 2.6 is the only PICC that we have that you can draw blood off of one of the lumens, and one of those lumens can be hep locked. So the 2 French is something I think we probably just don't use a whole lot, unless we're not able to get a 2.6 in if it's a really small baby year. So the 2 French, just as a reminder, can't be hep locked. Something needs to be running through each port of those of that PICC, and you also can't draw blood off it. Anything less than a 2.6, the risk of thrombus is too high, so it's not recommended to draw blood off that. 2.6 is sort of like our favorite line because it gives you the ability to do everything. We can draw blood off it, we can infuse just about anything, and they tend to last.
And for the first years, you guys probably know this, but just to highlight what Kristen just said, that's so important that if you have a 1 kilo baby or using a 2.0 double lumen, think about how much fluid you're going to need, and like you're sort of stuck with that much fluid for the life of the line. That's usually like the biggest issue, not the fact that there's, you know, 2 lumens or 1 or you can't draw blood. It's just like how much fluid you're going to expose that baby to.
True.
We also have one other line that isn't used that often, which is a 1.9. Sometimes you'll see babies have a reaction to one material or the other. So sometimes we'll switch from a polyurethane line to a silicone line just to kind of prevent like a phlebitis, basically, from a sensitivity. There's no way to know if the baby is going to react one way or the other until it's in, and it's not something that we would necessarily go to as a first choice, but we might line exchange it or place a new one with a different material if necessary.
So the E-piv is the extended well peripheral IV, like we just talked a little bit about. This, a little bit repetitive, but used for infants with difficult IV access to, otherwise known as divas, who need short-term IV fluids or medications. Placed under sterile technique, but it's not a central line. The reason we place it sterilely is because you actually have to touch the catheter to advance it into the baby, so you really need to have, you just need to be sterile for that reason alone. They're either 4 or 6 centimeters in length. They're pretty stiff when you take them out of the package, but it softens after insertion. And technically, we recommend having continuous IV fluid infusing through it. That is a recommendation for the E-piv. But like Krista said, it can be HEP-locked on a case-by-case basis. We would rather have it HEP-locked than have those lines pulled, because we usually don't put these in unless it's a kid that really is a difficult to access. So we'd rather preserve the line and HEP-lock it. But when possible, it's preferable to have something running through it. If it's at a KVO rate, which is 1 cc an hour, then it needs to be heparinized. If it's running at more than that, it doesn't. You can use it to infuse blood. The dressing is assessed by our team every 7 days, and just like the PICC line, dressing gets changed every 7 days, or if it's loose or spoiled. It can be in place for up to 29 days. And to remove it, you just soak the insertion site with sterile saline before pulling the catheter. It can be done by the bedside RN or us. We do secure these with a glue called Secure Port IV glue, which is on that little station over there. And we've had some success with having you stay in longer since we've been using the glue to secure that. And we may be expanding the use of the glue for other lines too, but right now it's just the E-piv. And then document the reason for removal in EPIC if you need to take one out. A stat seal and or a biopatch can be used per protocol. Secure Port IV glue is used at the insertion site, like I just said. So we, treat it the same as we do with the PICCs. If it's a new line, after you sort of put the couple of drops of glue to keep it in place, the stat seal goes on after that, and then when you change the dressing, the biopatch replaces it at a week. And to prevent line occlusions, the E-piv catheters require continuous infused heparinized fluid. We just talked about this. And so this is our venous access decision tree. This is really helpful in helping you sort of just for decision making regarding what type of access a baby should get or what they need. People tend to forget about this, but it really can sort of walk you through, what you should be thinking for what type of patient you have. And so this is posted in most of the teaming stations. It's in the rooms, I believe, in all of the book of, helpful things to know about that are in all of the baby's rooms. And it's posted multiple places around the unit. But, when in doubt, ask questions. We're happy to help you troubleshoot.
We developed this in large part because as experienced clinicians and nurses in particular, we're very used to just putting in another PIV. And we always feel like we can get by on another PIV unless the baby really needs central access. And there's been a big push within the vascular access world more recently. One, identifying peripheral IVs as a source of infection, and multiple sticks increasing the baby's infection risk. Also identifying the trauma that a baby experiences from multiple sticks. So there's a big push, which is impossible in our world, but for one admission with one device, we can't ever achieve that, but we should all be working to minimize the number of devices and the number of sticks that the baby receives, which is a tricky balance when you're talking about peripheral versus central access and that, you know, like a vascular access team member versus a bedside nurse attempting for another access site. So this is a really good resource to kind of tease out some of that.
Yeah. We also have, in addition to the vascular access decision tree, we have something called a PIV algorithm, and that's another part of what Chris is talking about, to just minimize the number of sticks per baby that, you know, the bedside nurse can try twice. We have a minimum. It's a 2-stick rule for everybody. Us, you, nobody gets more than 2 sticks. But after, you know, the bedside nurse has tried twice, they really should be escalating to somebody more experienced or finding out from the charge nurse who that is, because we've had a problem with babies getting way too many sticks, and then at the, you know, by the time you get called in to you know, help with access, you're very limited as to what you can work with because of it's just gotten too far. So anyway, thank you for that. Techniques and PICC placement for neonates. This will mean more to you when we can actually show you what the, you know, what the equipment is at each station. The Seldinger technique is named for Dr. Sven Seldinger. It's a method to insert tubes or catheters over a guide wire to the final tip location. That's what we use here. They don't use it everywhere. A lot of places it's just a straight introducer and then the PICC just goes in. This is a more updated version. Our success rates have increased greatly since 10 years ago, I think we started using MST. The modified Seldinger technique is an adaptation of the Seldinger technique, the introducer needle that you see, which comes in the kit, and the sheath dilator, tearaway sheath, and dilator, guide wire holder, and feeder all comes as one part of a kit, and we'll actually show you how to use that at the E-piv station and also at the PICC station. So the clinician uses a small needle or angiocath to access the vein, just like our PIV catheters, our 24-gauge catheter. The needle is, and then we insert the needle through the angiocath, and then the angiocath gets removed over the wire. The wire stays in the baby, and it allows for insertion of a small caliber short and, going through the the IV catheter allows for the insertion of the wire, and it's very short and flexible and stays in the baby. The catheter is then removed over the wire while the wire stands as sort of a placeholder in the vein, and then the introducer of the dilator is advanced over the wire into the skin through the skin. Sometimes you have to apply a little bit of force to make that happen, and then the wire is removed. The PICC is then fed through the introducer to the desired depth, and the introducer is then removed. Success rates are supposedly reported between 83 and 100%. The documented first attempt success rates increases from 47 to 74.7 with the use of MST. There's also been a reduction in the procedure time, procedure-related stress, and cost, fewer x-rays and supplies required. Technique is not utilized in the, has not been utilized in the neonatal population until recently, but this is maybe we need to update this slide because it has been around for a while now. But there used to be an issue with products not being small enough for our population. Now there's plenty of products. So we can now accommodate neonates with birth weights as low or even less than 500 grams. We do have a 26-gauge catheter for those really tiny babies. The vein can be accessed with a small gauge needle and then dilated to accommodate different size catheters. Benefits of vascular access and ultrasound technology. We do have our ultrasound machine over here, which we will go over. We really need to get better with ultrasound. We need to get up and running with this. It really is the gold standard in the vascular access industry. It provides real-time visualization of the vasculature to guide the needle for PICC placement, and you'll see that actually when we show you. It allows for visualization of deeper vascular structures that are inaccessible with transillumination, and it provides measuring tools to accommodate different size PICC catheters. It's portable and easy to clean for infection control practices. That's a picture of it. That's what a vessel looks like on ultrasound, the big black hole.
That's the vessel.
Yep.
And that.
Yeah.
And that.
So this is the little hockey stick wand that we have on this machine, and we'll show you how to use it. The PICC line insertion policy is in with all of the other NICU policies. There's a couple of different ways to get there in EPIC, not through EPIC. There's multiple ways to access the policies. We also have them printed in a notebook. So if you
They're
don't want
on the pediatrics website with the interdisciplinary policies.
Yeah, on the NICU intranet.
On the NICU
Right,
intranet.
yeah, so which I think we all have the same access to that. And the documentation there is in EPIC. Well, that's the consent form. It's in the cart. The secretaries also have it. This is our logbook that I was talking about. We put a patient sticker and all the details about the line. And then this is the notebook fellow PICC line competency record. For anyone who is interested, we've sort of had dwindling interest in people wanting to actually learn how to do this. And part of it's because you guys are so busy and because of the coverage and being pulled in 100 different directions. So we get it, believe me, but we're also happy to have you do this with us if you would like to learn how to insert a line. Some people were very interested, but I really think it's mostly a time factor.
Yeah, it's one of those things where if you want to do this, you're going to have to hunt us down and make the time.
Yeah.
And we're happy to do it with you.
Yeah, any one of us. So this is the documentation in EPIC. This is the central line insertion checklist. The bedside nurse will make sure that all of these points are met, and that's that. And then there's a PICC procedure note with all the details of the line, also in EPIC, and the physician central line note. So the PICC line procedure note must contain the size of the line, the extremity circumference, and it will prompt you just to fill in all these numbers. And then for removal of a PICC line, a note should be completed, and the length of the catheter that you removed should be documented.
Is there a slide about PICC removal in here?
I don't remember.
So you guys might frequently get called to remove a PICC line because that is something that is considered really time sensitive. If the baby doesn't need it anymore, it's not something that physicians tend to want to leave in for an extra 12 hours until one of us gets here. So the only thing we would say is read a note, know how much length you're supposed to be taking out. And when you remove a PICC line, it should be 1 centimeter at a time. If you feel resistance, you need to stop. Give the vessel a chance to stop constricting. You can add heat sometimes if you're feeling any resistance at all. It's not a line that you just yank out. It's 1 centimeter at a time, counting the centimeters, making sure that there's no resistance as you go.
And generally, the rule in the unit is if you put them in, you take them out. So we can also remove them, but if we're not here, you might get us to do it. Central line dressing changes. That'll be this station right over here. There's a little arm to just show you how to do it. So the indications would be a lifting or loose tegaderm if it becomes non-occlusive, dry blood under the tegaderm, dressing, soil with stool, urine, or emesis. That can happen with a lot of the lower extremity PICCs. Dressing that per our policy, the dressing needs to be changed at least every 7 days with the use of a stat seal or biopatch. And like Krista said before, if there is no stat seal or biopatch, as long as the dressing is occlusive and looks good, it doesn't need to be changed. Intact central line dressings are right here. They look like. And then the stat seal, as you can see on both of these, it looks like kind of a sandy, gritty mess underneath. That's actually what it should look like. So when it's actually working and gets broken down by the blood, that's the result, and that's what we wanted to do. Some people panic when they see that and they think there's something wrong with the stat seal, but it's not. And then the biopatch looks like that, and it actually says stat seal or biopatch. Some people tend to use these terms interchangeably, and they're not. They do different things. The biopatch is the one that replaces the stat seal at a week, and that is impregnated with the chlorhexidine.
Trying to figure out what these are trying to show. Is one wet?
Yeah, and lifting, like the one on the, the one on the left also has a lot of the PICC hanging out, and it shouldn't. That should all be underneath the dressing. See how it has the markings on the PICC? That should be sort of coiled and secured under the dressing, and the only part that should be hanging out is the actual line that's not
This is okay.
intended to go into the baby. Yep, that one's fine. But then there's lifting, so that would need to be changed. And then this is what we call our teddy bear tegaderm, and it just has that window so you can see the site a little bit better. PICC line troubleshooting. There's a lot of things we can do to preserve lines before we resort to pulling them out. Catheter obstruction, there's a couple of ways to treat that. And it's important to distinguish between, if you can, between a clotted line versus a kink line. Consideration should be given to what was the minimal flow rate. You will occasionally see from time to time people seem to be under the impression that 0.8 is an okay rate to run a PICC at. That is against our policy, especially the 1.4 should never be at less than 1 cc an hour. We've had a lot of lines clot off that have been running at less than the KVO rate. And even for the little kids, and we understand trying to, you're trying to maximize their TPN, and you need the fluid for other things. But if you lose the line, they're not going to get any of it. So we definitely need the rate to be at 1 cc an hour. The need for TPA or alteplase to as a thrombolytic agent can be done by our team or you guys. There's a very specific policy for that. We have done this many times, and very often it does work. But if the dressing has just been changed and all of a sudden the IV pump is beeping, it's very possible that there's a kink in the line, because when you think about how tiny the lines are and someone just changed the dressing, it could be that they just taped it in such a way that that's the problem. So the dressing should be changed so that we can rule out any other mechanical problem with the line. Mechanical phlebitis most commonly is reported within 72 hours to 1 week post-line insertion. Signs and symptoms are edema, redness, and palpable venous cord according. We usually will treat that initially. If the line is working well, but the nurse calls you and asks you to look at the extremity because they don't like the way it looks. So usually we'll try some warm compresses and elevation of the limb to see if that improves. But if the symptoms persist, then obviously the line would need to come out. Dependent edema can occur below the insertion site on the extremity and can be normal. We do see a lot of this actually, and the line's perfectly fine. And sometimes we just kind of monitor it and watch it, make sure things don't get worse. The dressing should not be completely around the extremity to prevent blood flow restriction. Obviously, we don't want to tourniquet the extremity. And these are some references that we use just to put this together.
The first thing you're going to do when you are going to place a PICC line is make sure you have consent. That's in the baby's bedside binder if we've gotten it previously, or if you get it yourself, obviously you'll speak to the parents. The next thing you're going to do is come into the room and wash your hands. We've already set up the tray for you, so I'll go through each piece that we have, kind of as I show you the insertion procedure. But you'll use a measuring tape from the baby's bedside cart to measure the baby, because you're going to cut the line before you even get started. So you're going to measure from your chosen insertion site. So if we're doing like an arm, you might measure from the elbow, and you just follow the track of the line, okay, up the arm, across the chest, and basically to the nipple line on the baby. And then it's okay if you have 1 or 2 centimeters too long. It's less okay if you're 1 or 2 centimeters too short. So we have a tendency to overestimate so that we can be sure we get it into the right spot. This is going to be your line cutter. So you have different hole sizes. It kind of doesn't matter what you use, but you can see here the very middle. So you want to move wherever you're going to cut your line, you put it right here on that middle piece, okay? So we've decided we're going to place this 1.9 argon PICC line and say we're going to place it to 17 centimeters on a 3 kilo 37 weeker. This is 0, so your initial dash line is 0, and then you can just count up 5, 10, 15, 16, 17. All right, so we've got a fair amount of line that we're going to cut off.
And we have to use the cutter because it's a straight cut as opposed to the scissors because it's a frayed ending, which increases the risk of collapsing.
We are sterile at this point, so I've scrubbed my hands. I've got sterile gloves, gown, and hat on. Okay, so if this is 2019, 18, here's my 17 mark. So 15, 16, 17, I'm going to put right to the middle and cut. Okay. We've had,
Just push up on the ejecting
so
point.
you just
Got it.
push. This should be half normal saline with heparin. Okay, that's what we use to place a PICC line. And we're going to flush through the line. So there's got heparinized fluid in it.
And the nurse will get that for you out of the Omnisol.
The nurse will hold that up for you, and you will be sterile.
It's like the needle that we do for UVC.
Correct.
Okay.
Same thing. So we've got our line ready. We have our baby. If we can, we try to do 2 people, somebody to help stabilize the baby and keep it calm. If we can't, there are ways we can show you how to kind of keep the baby still without help. Tourniquet, it's always helpful. And I think we're ready to start, right? So you take your peripheral IV, just as regular IV catheter.
Drape stuff under here too.
Oh,
Just
Yeah,
this all
so-
comes in the kit.
all right. So we're gonna clean the baby.
You don't have to. I just wanted to show you that was in there.
Well, so here we've got a couple of options. You've got a chlorhexidine swab, the ChloroPrep, and the betadine. So babies 28 weeks and below, you use betadine. Above 28 weeks, you can use chlorhexidine, plus 7 days. Okay, for the chlorhexidine. 28 weeks plus 7 days, so 29 weeks up to full term. Less than 28 for this, for the betadine.
And here's all the sterile towels too that are right in front of the couch to drape the baby, and then the fenestrated one.
We are going to drape the baby from head to toe. Not in the adult world, you'll see just the extremity drapes, but we drape the head all the way down to the toe. I like to drape the bed. I drape everything. The betadine has a 2-minute dry time. The chlorhexidine has a 30-second dry time, and that is a friction scrub when you're cleaning it. So we're friction scrub the site. We've got our peripheral IV.
We'll pretend that's right.
Do you want to drape it?
Sure.
You're just going to take your needle and access the vein. You can advance your catheter just a smidgen. It does not have to go all the way in, okay? Remove your needle. Take off your tourniquet. Here's your MST kit. This is your guide wire, okay? So this should be pouring blood out at you at this point. And you're going to just take the guide wire and you're going to advance it. It goes in smooth like butter, okay? You don't need to advance it all that far. You just need to get it in as far as you're going to be placing your vein dilator. At this point, we usually use like a 2x2, hold pressure at your site, and you're just going to pull your catheter off while the guide wire stays inside the baby, okay?
And everybody at one time or another has pulled the wire out with the catheter, just
Yeah.
FYI.
It's horrible.
Yeah, it is awful.
This is usually now has little bits of blood drops hanging on it. In order to keep them from clotting, we just wipe it down, okay?
And holding the pressure as you take the catheter off the way to prevent it from.
Correct.
And
This
this
is-
is why this is a 2-person job. It really is hard to do yourself.
This is your vein dilator, okay? You need good light and good eyes because you're going to take your dilator
And another sterile person, this is another reason why it's a 2-person job.
And
to sort of
thread
hold
it.
still.
over the wire. I never took this piece off. There we go. So you'll thread it straight over the wire. Now at this point, you're inserting your vein dilator slowly, like you would an IV catheter, okay? But when you reach the skin, it does require a little bit of pressure here, all right? You should get blood return through the hub here. You're gonna remove the internal dilator along with the wire, okay? So this removes from the baby. You put that aside. Here you have just a tearaway introducer at this point. And then you take your PICC line.
Hopefully you'll have blood pouring out.
Yep. Be blood pouring out.
If you don't, you're probably not in.
You just use your tweezers and thread it into the baby as far as you plan for it to go. Okay? This can be a really tricky part of your procedure. Sometimes, like right now, it doesn't want to advance through the catheter. Sometimes you'll get, it's funny, that was very true to life because it didn't want to go and I pulled back and it went in. Sometimes you'll get halfway in and then your line will stop. And it's just the way the baby's veins twist and turn, and it can be very frustrating, but there are lots of different maneuvers that we do, moving the baby's arms one way or another, getting the baby's arm up. If you're in a leg, getting the hips up, adducting your hips, and trying to advance in all these different positions. Different things affect a baby's ability to, like your ability to thread, like a baby on an oscillator, for example, is much harder to thread through the right arm than the left. Site selection is kind of a bigger issue, but in any case, you're going to thread the line to the 17 centimeters, however far you want it to go. When it's time, when you're in, you're going to pull your dilator out, and it tears away. So you just pop it open, okay, and you pull out a little bit more, and get it all the way off. If you have some lines still sticking out, it's at this point it's okay. You can just thread it into the baby's skin the rest of the way. All right. Once your line is placed, thank you. You should always have blood return. Okay, so you'll just aspirate, make sure you have a little bit of blood return, and then flush and make sure it flushes easily. If you don't have blood return, you're not in the right spot. If you can't flush it, it's not a good line. At this point, we tend to just take one little steri strip, put it over the top, and ask for x-ray. So we have blood return, we'll steri strip the line, ask for x-ray to come, and check position. Once we've determined that it's in the right spot, we dress it. So we're going to use a stat seal, if I have one. So this is bleeding because we've dilated the vein and it's a teeny tiny little line. So we use our little stat seal here. This is 2 minutes of pressure, okay?
And that can be any gestational age, the stat seal. Okay.
Yep. And then, yes, it's already open. Depending on the size of the baby, you'll pick your size of dressing. One is smaller, one is bigger. Your dressing, yeah. This is your grip lock. This one doesn't fit in all that well.
I hate those.
Your wings are going to go here, okay? If we had this much line sticking out, it'd be all coiled around. Okay, we tend not to have this much line sticking out. Wings are in your grip lock. This piece peels off, okay? And you can close the flap here. And then you've got two little wings underneath. As you pull off, it'll stick down to the baby's skin. Okay, other side. Pull this one off, stick it onto the baby's skin. This is on your insertion site. And then your dressing, your window is going to go, you're going to put your insertion site right in the middle of your window. You may have, especially if it's a smaller baby, you may have your grip lock hanging out a little bit, and that's okay. Put everything down and peel these edges off. And then there's all sorts of ways to tape these down. Sometimes we'll use steri strips to make a little chevron along the wings. And then we have these guys go over the top. Okay? And that's all there is to it. The dressing change date and the placement date is documented in EPIC. We don't necessarily write the date and time on the tape. Here at other places you'll see that they do. And then of course if you come into a baby and you see the dressing pulling up like this one is, you're going to immediately say that that needs to be changed. So that's all there is to it.
So I'm just going to do a dressing change because it's likely that you probably will need to do this. Obviously, I went down, hat, and sterile gloves on, and I also have another pair of sterile gloves. I take off the old dressing and then I change my gloves to handle all the sterile stuff. So when you open the dressing kit, this is what the dressing kit looks like, and it tells you on the front what everything that's in here. The only thing that isn't in here is the teddy bear tegaderm. So once you open this kit, you just need to flip one of those onto the field, which Krista has already done. And then you have everything else that you need. We tend not to use these things, the skin protectant and the alcohol swab, but we do use the chlorhexidine scrubber, which is here, and it has a bio patch already in the package. So I'm going to open that. And so gloved, gowned, ready to go. I usually use these tweezers to help to loosen the old dressing because sometimes it can be really tricky to get it off. So I'm going to remove the old dressing. And as you get down to once you get these little chevron strips off, you just have to be really careful not to pull the line with it. This teddy bear tegaderm is really sticky. So I just usually loosen it around the edges. The bio patch or the stat seal will likely be attached to the dressing. And then there's usually another chevron underneath, or a steri strip. You never know what you're going to find under here. All right, and then this is Mepitel, like on some of the smaller babies, instead of using the grip lock, because the grip lock's a little bit, it can be way too big for like a 24-weeker. We use this instead just to protect their skin from this part. Do you want to just give me the grip lock from that? And then you want to have help when you do this too. You definitely want the nurse to be in the room with you, because now you've got the dressing off. You need to change your gloves because I'm not sterile, obviously taking off all this dirty stuff. And the last thing you want the baby to do is to do this and the line to go flying, obviously. So I usually have somebody, under the sterile drape, just kind of holding the baby's arm. So then I'm going to change my gloves. Activate the chlorhexidine scrubber. You have to kind of shake it up a little bit and squeeze together these two wings. And then you're going to do like a little friction scrub around the site. I usually keep my thumb on this just to prevent the line from snagging on something and going flying. You're going to just kind of clean everything up, make it look nice. You may be removing a stat seal or another bio patch. You can clean all that sandy stuff off that the stat seal creates. Wait for it to dry for at least 30 seconds. And then you're going to apply your new dressing. So the stat seal, the bio patch is right here. It says bio patch. That's going to go right over the insertion site. And then I usually put, actually I'll do this first, a steri strip back over the line itself just to kind of keep it to the skin. You also want to take note at how much line is out of the baby. Sometimes the lines migrate out or in. You never want to push a line in, obviously, but if there's a lot out, you might need to figure out where exactly that line is and if it's still central. So then the bio patch goes right over the steri strip along with the teddy bear tegaderm. I actually think we need a larger, this might work, a larger one. because you want to make sure you get all of this under the dressing. So that goes just like that. Just like that. And then usually chevron underneath the line. Just like that. And then cover it with the teddy bears. There we go. Yep. Questions? It's pretty straightforward. So then over here is the E-piv.
All right, we have two different kinds of E-pivs. I'm going to show you just one technique because the other technique you've already learned. If you're going to use the NeoMagic E-piv, you place it like you place a PICC line. You access the vein with a catheter, you pass your guide wire, you put in your vein dilator, and then you pass your E-piv through the vein dilator. So we've already covered that. This is just, it's a different type of E-piv. It comes with its own guide wire.
And it's just a matter of preference. There's really no reason to use one over the other. It's just...
This is a 4 centimeter E-piv. We also have 6 centimeters. Your biggest consideration with length is that you don't want it to terminate in a joint. So you don't want to terminate at the elbow or at the shoulder. You want it to be below the joint. Okay, so with this guy, same thing. I'm sterile. We've sterilized the baby's arm. We've draped the baby head to toe with sterile dressings. And now we're going to access the vein with a steel needle rather than a catheter. Okay, the steel needle, it's short, bevel up. You're just going to go just under the skin into the vein. You're going to get good blood return here. At this point, you'll take the wire that came with the E-piv and pass it through your steel needle. Just like we had our 2x2s before, you put a little bit of pressure, take your steel needle off, okay? And then you're going to take your E-piv, which has been flushed with heparinized saline. Actually, you can use normal saline on the E-pivs. And the same thing, you're going to thread it carefully
This is the hardest part.
over the wire, okay? Once you have it over the wire, you just advance it under the baby's skin. Over
This
the
is why
wire.
it has to be a sterile procedure, because she has
I'm
to touch
touching.
the actual catheter going into the baby, which we wouldn't if it was just a PIV.
This is actually a nice demonstration. You can see as I'm advancing this catheter, I'm also advancing the wire up here. Do you see that? When you're placing an E-piv, you use a push and pull. You push the E-piv in and you pull that wire out. I don't know with this particular model if it's going to go all the way in. Push and pull until your E-piv is all the way in. Okay? You will have blood return here. Okay? If you don't have blood return, you're not in. Again, it should flush easily and you should be able to aspirate a little bit of blood. Right now we're not using these to draw blood off of, but other institutions do. So good placement requires blood return. This is our glue. Right now we're using these on E-pivs only. Okay, so once your line is in, we just open this up. You activate it by pushing the brown cap down. And it just takes one little drop right there at the insertion site. Maybe two if you feel like your drop didn't hit the right spot. And a 2-minute dry time. Once it's dry, you dress it the same way you've dressed everything else. And that's it.
So this is what we practice on. The Blue Bandit, it's called. Is it the Blue Bandit or the Blue Phantom? That's great. Something like that. And this is a bigger needle, so I'm just going to use this for practice. I feel like you can see it better on the ultrasound machine. So this is already turned on. This is the wand that we use that's small for the neonate. It's hard to do from this angle, but You're going to hold the ultrasound wand in your non-dominant hand. So whatever hand you're going to use to stick, put it in the opposite hand. So I'm right-handed, so I'm going to use my left. We're going to use some ultrasound gel, which just as a note, ultrasound gel comes in the package with the transilluminator cover. And this is all set up for a neonate.
Okay. So you don't have to adjust the
No,
depth.
so you don't really need to know about all the dials
Okay.
and the numbers and all that, because, oh, there we go. Oh, that's pretty obvious.
Deeper.
Thank you. Yeah, so it should have actually been at the depth that we would expect it to be at. So once you locate the vessel, you want to get the image of the vessel in the center of the screen. And then there is a little mark right here on the wand. And you are going to go in sort of at a 45-degree angle. Back a little bit, like a centimeter from the wand. And you will see the needle go into the vessel when it gets to the appropriate depth. See that? The tip. So I'm moving a little bit, so I'm not great at this because we don't do it a whole lot. But you want to see that tip go right through, ideally right through the top of that vessel. And you guys can practice with this if you want to. I didn't need to do that. Hang on. I just want you to see what it looks like when you actually puncture the vessel and you just lower your angle and then advance the catheter into the vessel.
Okay.
There we go. So now I'm in the vessel, because there's the tip right there. So then, at that point, you should see a blood flash. You want to lower your angle, like almost flush with the skin, and advance the catheter into the vessel. And theoretically, we should have blood pouring out here. We tend to use this, we really need to get better at using it for all insertions, but we tend to use it now as a sort of a way to assess the baby's vessels if we can't really see them too well with the transilluminator. If anybody wants to try, feel free. It's kind of fun to play with. Do you have anything to add to that with the ultrasound?
No, I mean there are a lot of fun little functions, just in terms of like finding veins and finding vein sizes and determining veins versus arteries and all of that stuff. So if you're ever at a point where you're using it or playing with it, just like grab one of us and we can go through it with you.
Yeah.
Arteries pulse,
Yeah.
and you'll see them pulsing on the.
Yeah, and you won't be able to totally occlude it, whereas the vein will.
Does this one have like the Doppler capabilities
Yeah.
that you can see?
It does. Yep.
It also has like measuring capabilities. You can change kind of like gain and depth and all sorts of things on the screen. But that was like a 3-day course full time for us to learn it all.
Yeah. And to see it on, real patients.
Yeah.
This is obviously not.
Questions?
That's great. Thank
Sorry, it
you.
was a lot of just.
That was
The
wonderful.
worst part is all the equipment. There's so much.
Yeah. No, that
But,
was wonderful.
Just reach out. We're happy to help, and we're happy to help you put a line in any baby. So.
Alright, so now you just take the wire and you basically just slide it slowly in there. And if it goes in, it should slide in very easily.
okay.
You should not get any resistance. So then I just took that off. And really you just needed to go in a couple of centimeters. Well, in a couple inches really. So then if you're by yourself, what you would do at this point is sort of hold the wings like this. Hold the needle, hold the wire, and then I sort of just start sliding it out. And sometimes, which since I have a helper, I'll use my helper, but technically I would just sort of slide a little, make sure I slide in, because the wire will move with your angiocath. So I'm just just gonna slide that out and then grab a gauze if you don't mind.
The 2x2 or
Yep,
the
that's
bigger
fine.
one?
Whatever. Just sort of dab. And then I always wipe the needle off. And then if you want to just hand me the catheter itself. Perfect. I threw it right on. Okay. And then this just feeds right over the wire. Do you mind just holding the wire? Perfect. It's always nice to have a extra hand. Okay, so as I go in, perfect. She has the end of the wire. So now this also just sort of slides gently into the skin.
Okay.
And as you sort of go into the skin, you can kind of slide the wire back a little. And then go in and slide a little. Because
Okay.
the wire will continue to advance with
Okay.
with the line itself. So you want to continue to slide in and back. Okay. And then when you take it out, sometimes you get a ton of blood return coming back at you, or sometimes you don't get any. It varies. It doesn't mean it's not in. I think it is in. And then just the flush. So if you want to just put the flush right on the end. Okay. And then you can just go ahead and flush it. And how does it flush?
Beautifully.
Perfect. So